This is Jerry Hesch presenting a case which I've titled Hypermobility Syndrome in a male, and a better title would be Mixed Hypermobility Syndrome, because there are parts of his body that are hypermobile and parts that seem to be normal. And he presents with a fairly acute bilateral knee pain, especially on the right, which was enhanced with some rehab exercises performed recently. And there is a connection with his hip that we will speak about and speak to. And I work at the Hesch Institute in Henderson, Nevada, very close to Las Vegas, Nevada. And our client comes from out of state. He's seen a couple of clinicians for this injury, which started out as a back injury but greatly enhanced his knee pain when he was doing some squat-like exercises. If you were to observe his feet when he walks, you would agree that he appears to be rather hypermobile, definitely pronates throughout the foot and ankle bilaterally. And when you look at his knee on the left, we're going to ignore the right side for now, it does not appear to hyperextend excessively. Appears fairly normal in terms of the feel of the connective tissue, and yet when you look at his elbow visually appears to hyperextend, but it also has what I'm going to describe as a clunking feel. Is that correct?
Yeah,
Is that,
I could feel it.
what does that feel like to you when I do that?
Kind of like just what you said, very clunky.
Yeah, like a bone on bone. Is that a fair statement?
Yes.
Okay, and certainly has hypermobility in his digits. Okay, so his MP extends almost to 90, very, very close to 90. I think I could probably force it. Can you show us what you can do with your thumb? Yeah, so you can see the hyperextension, the distal IP, and then show us flexion at the MP there. So I can't get anywhere near that. And pretty good wrist mobility in both directions. Your wrist extension is, my gosh, that's certainly, that's 90. That's 90 degrees. So he does have hypermobility up in his shoulders. So I have to call this a mixed hypermobility. I screened his hips, and I can't call them hypermobile. Focusing back on the knee, the patella on the left I can lift. If I squeeze it, I can elevate it. On the right, I can squeeze the skin. I'm trying to squeeze under that patella, and I can't get it to move. And I'm sorry, but I'm the guy doing the filming also. My staff is gone for the day. So, mid-femur on the left, I can take up the slack, and I can spring it. On the right side, very rigid. Okay? I've already done a screen. We spent an hour going through the history and doing a whole body screen. Do not implicate any significant hip pathology. However, he does have a definite reduction in extension in his right hip, which may influence his knee somewhat. He does have some crepitus in both knees. On the right side, he does have a positive drawer. He has a surprising amount of AP mobility, which you may or may not be able to see in the camera. Let me get your foot planted there. It's a little high up. Yeah, I can, that's distinctly different than on this side.
Yeah, you could feel
I just can't.
I'm
I'm sure we're missing that with the camera, but this is just very, very solid. Would you lie on your stomach so I can demonstrate the hip motion?
Can I just have that pillow again?
Yeah, you bet. So because of knee pain, he's more comfortable if I put a pillow under his ankle on the right side.
Thank you.
Yep. So I'm going to demonstrate his hip motion on the left. And on the right. I can force it to about 5 degrees, but that's the limit. How does it feel?
Just feels like tight, like you can't make it go anymore. On this side, you probably could have even kept going.
And how much force am I using?
I mean, equal force on both sides.
Okay.
But
So what I would like to do is go ahead and treat that hip right away. It'll take me less than 30 seconds. And so I'll just turn the camera to the skeleton. And I'm curious to see if that will affect the patellar mobility. So I'll be just very direct here, but very gentle. If it's uncomfortable, please let me know. So the key is that I treat it once, and then I teach you how to keep it.
Okay.
Okay? That's the plan. Alright, so let me bring the camera back. So I like these one-time treatments, where we teach the client how to manage for himself. Could you lie on your back, please? And the treatment is just common sense. There's nothing magical. It's not, you know, it is, the results happen quickly, but it's using logic. Okay, so now you can see there is mobility in that femur. What happens when I squeeze that patella?
It was locked and stuck before.
Can you talk louder?
It was just locked and stuck before.
And what happens now?
Now there's definitely more movement.
Okay.
Maybe not as much as the other side.
Okay. How about this test?
Yeah, that's...
I can get a little backward motion, okay?
Yeah.
Feels like there's more stability forward, but I do feel I can still create some posterior glide, but not as much anterior glide. Could you walk and give us some feedback?
Sure.
Now, I want to limit the feedback to the hip and the knee, initially at least, okay?
Okay.
I know we didn't film you initially, so it's not a comparison. I know there's more work to be done with you with respect to the pelvis and the rest of your body, but for now we just want to focus on the relationship between the hip, the reduction in hip range of motion, and how it affected your knee. And you could also go from sitting to stand if you want to. Your thoughts?
More lap.
Maybe it's too subtle.
No, I feel a difference. I'm just trying to put it to words. Actually, doesn't seem to hurt as much, for sure, I would say. But the pain has been kind of coming in and out.
Right. So as the patient, as the person who feels the pain, the only intervention that we did was something that was directed at your right hip. And so I worked at increasing your hip range of motion. And after that, we demonstrated that there was then more play when we would impart a spring test at the femur. And we demonstrated that there was a lack of patellar mobility, because basically your hip was maintained in a flex position, as was your knee. Even though that was subtle,
Right.
there was a limited amount of patellar lift. Okay, so after we treated the hip motion, I was then able to squeeze the patella and it popped right up, right?
Right.
So that's all that we did. It was a very, very brief intervention.
I feel like before it was not tracking as well. And now it feels like I don't hear that pop that I would have before.
Okay. So, I mean, it's things that everyone knows, that the hip is connected to the knee, obviously. It's the other end of the same bone, that there are functional relationships where sometimes for knee pain, part of the treatment is going to be to address the hip, and this isn't the total treatment that needs. You know and I know that you need strengthening, and the process needs to continue. We need to continue to look at the behavior of the knee. We haven't put it all together yet. We still have excessive posterior mobility in that joint, but I think that we're off to a good start here, and that was the point I wanted to make. So this doesn't encapsulate everything we want to do for the knee. It doesn't solve the knee, but it gives us a good on-ramp. So this is such an interesting case. We're going to stop this film, but we're going to film you one more time, and then we're going to focus more on the pelvic region and the upper body. So I will stop here.